Um, Welcome. And this is a very jam-packed full of um, lots of information. So I'm going to get as far as I get, and the rest of it, if you want, you can get it online. Bridget says she has it and she'll be able to send it out to everybody if they want the full PowerPoint. Today, I'm going to talk about when to worry about a rash, mostly focusing on inpatient clinical outcomes versus clinical presentation. My goal today is to actually get through case 1 and case 2 so we can compare and contrast. We'll start with case 1. Hang on one sec. This is a 10-year-old male with no significant past history who presents to the ER with 4 days of fever, body rash, sore throat, vomiting, diarrhea, diffuse abdominal pain, cough, and hypotension. He has a diffuse erythematous, papular, and urticarial rash on his trunk, extremities, and this includes the palms and soles. He's also got bright red eyes, without any discharge, dry, chapped lips, if you can see that in the picture. I like pictures, they show a lot. And a strawberry tongue and dry mucous membranes. He complains of nausea and mild abdominal pain. If you can see his vitals here, he's tachycardic, a little tachypnic, hypotensive for his age, but still maintaining saturations. He's a little bit on the heavy side for his height and weight for age. If you calculated his BMI, he would be considered overweight. And his initial laboratory studies showed an elevated CRP, sed rate, procalcitonin, which are acute phase reactions, and a little bit of lymphopenia and thrombocytopenia. Sorry, my screen is blocking the end of my thing. So here's some more pictures. This is multisystem inflammatory syndrome associated with SARS-CoV-2, MIS-C. This is a developing process that started in 2019, and we're seeing it more and more as we get more people exposed and develop COVID. The most common types of rashes are over here. Morbilliform is probably the very commonest. The least common we see, but it's still possible, is petechiae and purpura. You can also see lividio reticularis and digital ulcers or dactylitis. It does affect the palms and soles, so it's another one to add to that list of rashes that affects the palms and soles. And it looks very similar to Kawasaki's. Multisystem inflammatory syndrome COVID is got several different people with definitions. I'm going with the CDC definition. This is kind of my overview. I want to review the definition, presentation, signs, and symptoms, kind of review what we think the pathophysiology is, what we can often confuse it with, what our treatment options are, and the prognosis. So the CDC clinical criteria for MIS-C is a fever over 38 degrees, equal to or over, with cardiovascular, more than one organ system involvement. Cardiovascular is more common, often involved with shock or low or hypotension. You can see low platelets and low lymphocyte counts. They often present with abdominal pain, vomiting, and diarrhea, and will look initially like an older kid with Kawasaki's type stigmata, with the strawberry tongue, hands and feet swelling, oral mucositis, and chapped lips and conjunctivitis. CDC definition is hyperinflammatory syndrome in patients under 21 years of age with a fever for more than 1 day, usually at least 3 days, elevated inflammatory markers. Ferritin, LDH, and IL-6 are also often used as inflammatory markers in larger settings. We usually use our CRP and our ESR. Affecting 2 or more organ systems. The most common organ systems are cardiac, renal, respiratory, hematologic, GI, dermatologic, or neurologic, with no possible alternate diagnosis. This is an important feature of MIS-C because it's basically a diagnosis of exclusion. He must have had a recent positive COVID infection or exposure within the last 4 weeks. So you can have a positive antibodies versus a positive or negative PCR. if you notice, there is kind of a little bit of a difference between different places of definitions for MIS-C. CDC says under 21, WHO says under 19, and Royal College in UK just says a child. And you can also see the fever is over 38 for over 24 hours here. This one's 38.5. This one says at least 3 days. So it's kind of a combination of all of these things. Definitely requiring multiple systems, hence multi-system. And hypotension or shock is usually a significant factor. Exposure to COVID at some point in the last 4 weeks, and no other obvious cause, such as sepsis. Again, this kind of reviews, I like pictures, like I said before. Often these will be the same things you see in the multi-system. They may come in with a headache. Sometimes they'll even be meningitic. They'll be tired. They'll be achy. They'll have a rash. They'll have a tummy ache. They may or may not have elevated liver enzymes. They can also come in with hyponatremia and renal failure. Most often they come in either stable or they come in completely decompensated shock. They can look toxic. This is an important differentiation too. Respiratory system, they can be hypoxemic. You might see infiltrates on x-ray, but most of the time, these kids don't have respiratory distress. In fact, if they're coming in after having been exposed to COVID previously, most of the acute illness has resolved, and this is a complication of or part of chronic COVID. If they do have a respiratory component, often that is part of cardiac illness. So it's low cardiac output or myositis of the cardiac of the heart that's causing the respiratory distress. They'll definitely be hypotensive, may or may not need ionotropes. We always start with fluids, but ionotropes are the next step. Sometimes they can even present in acute heart failure, myocarditis, arteritis, coronary artery dilation, and aneurysms are frequently seen. They can also have effusions, pericardial, as well as pleural effusions, going back to pulmonary. Sometimes if they have enough dysfunction, they may require ECMO. I don't think we're seeing this as often now that COVID is a little more controlled with our vaccine status, but it's still out there. Very often vomiting, abdominal pain, sometimes diarrhea. In the past, when we were first developing or realizing of this illness, they did exploratory laparotomies that showed mesenteric lymphadenopathy and or peritonitis, but no obstruction. So these GI symptoms can be pretty severe and look like an acute abdomen. Most commonly seen in the renal system is hyponatremia. It can also progress to acute kidney injury, including elevated creatinine and decreased GFR. When you look at HENT, you will see, oh, my bad. I want to go back. Yeah. Bilateral non-exudative. So this is not like a glued shut eye. This is a red eye that is bright red, but not exuding anything. Often limbic sparing. You'll see a strawberry tongue, cracked lips, stomatitis, and lymphadenopathy bilateral, usually anterior cervical lymphadenopathy. The rash is often macular, usually erythematous. You can also see some erythroderma on the hands, swelling of the hands and feet. That does eventually desquamate. Neurologically, you can see fatigue, altered mental status, headaches, irritability, encephalopathy. But musculoskeletal, you'll see myalgias, weakness, or chest pain, but no actual arthritis. Again, red eyes, cracked lips, strawberry tongue, myocardial dysfunction. They may or may not be coughing with hypoxia, abdominal pain. So this is a graphic that kind of elucidates the proposed initial evaluation for suspected MIS-C. We want to do a CBC. We want to do some basic chemistries, including liver functions with albumin and bilirubin. Cardiac markers, we look at troponin and pro-BNP. Urinalysis, mostly if you're worried about an alternate source like a UTI, but not, this is more to rule out MIS-C than to rule in MIS-C. We often want to do a blood gas with a lactate. Definitely want to do pro-inflammatory markers. Sometimes these kids will develop DIC, so we look at their coagulation panel, including fibrinogen and D-dimer. A CK and LDH, again, kind of falls in the inflammatory markers. A blood culture to make sure this isn't sepsis. We want to look for COVID. And then if you have a kid who's presenting with diarrhea, you consider doing stool studies, again, because this is a diagnosis of exclusion. Chest x-ray, abdominal ultrasound or CT, 12-lead EKG, and echo if they act like they have cardiac dysfunction or you have a confirmed abnormal EKG, and early consultation. Now, from the setting of Enloe, often if we have these kids, and I've done this several times already in the last several years, we refer these kids to a higher level of care, i.e. UC Davis or Sutter. They need to have a PICU. Often they are in the PICU for several days to weeks until they stabilize. This is a nice quick algorithm to determine if we're going down this road. Is the patient under 21 years of age and has all three of these findings? So we've got a kid who's got high fever, he's been exposed to COVID, and he's got abdominal pain and elevated or hypo. So we go over here, are they in shock? Yes, they're in shock. So we're going to do a full evaluation, tier 1 and tier 2. Tier 1 is screening evaluation was the previous slide, and tier 2 is more specific, BNP, troponin, the coags, those kind of things, EKG and echo. If you do a tier 1 evaluation, like say they weren't in shock, but you're still considering them with MIS-C, which is what we most commonly see here at Enloe, we have to rule out sepsis. So we definitely want to look and see if there's signs of sepsis as well. Then we look at their labs, and then if their labs are okay, it's not the end of the evaluation because these kids are still sick enough to be at the hospital. So we definitely want to continue monitoring them and see if things do develop over time. Like I said before, we often transfer these kids, especially if they have signs of shock, significant distress, especially neurologic changes. We'll get to this part about Kawasaki's in a little bit. If they have renal or hepatic injury, they definitely need to be seen at a PICU. If all they have is mild dehydration and a rash with a history of COVID exposure, it's okay to discharge them, but we definitely want to make sure they have good follow-up so that there's no change over time. Because this can happen at any time between COVID initial infection and 4 weeks later. More evaluation on the laboratory side, inflammatory markers, CBC. Now, to be clear, I do order LDH. I don't order these other ones, IL-6, IL-1, IL-17. We don't have that capability here at Enloe. These would be send-outs anyway, so there's no point in ordering them here. But if you do end up working at a higher level of care or at a higher institution that has a good lab, you might consider adding those. The two things we'll keep an eye out for, or three things on the metabolic panel: hyponatremia, hypoalbuminemia, and elevated creatinine. When you get if you have an elevated troponin and or pro-BNP, you get an echo and an EKG. You definitely want to see if there's evaluate the function of the ventricles. Also, you want to evaluate for coronary artery dilation or aneurysms. because those can develop as well. So what we think is happening, this is the pathophysiology, is that you either get COVID actively or asymptomatically were exposed to COVID, but this causes activation of your macrophage, and that stimulates your T helper cells as well as your acute phase reactants, the TNF alpha and your ILs. The T helper cell stimulates your B cells, which makes your antibodies. And then the cytokine release after you release the acute phase reactants also stimulate the immune response, and you kind of feed back into the macrophages over here to stimulate these B cells again, and you get a hyperimmune response. One thing that we're still trying to figure out is this genetic predisposition. Certain people will have the exact same symptoms and not develop this hyperimmune response, and other people will. So there is some component of a genetic predisposition in this process. And then you develop the signs and symptoms of MIS-C. Of note, direct viral injury is very unlikely. This is generally a reaction after the fact. If you notice, there's kind of 3 stages. Stage 1 is early infection. Stage 2 is kind of the pulmonary infection. If you develop anything, most kids do not have much of a pulmonary infection. Adults tend to, but not kids. And then stage 3 is this hyperimmune response, that the delayed reaction of MIS-C. And this kind of reviews what we just looked at on the picture. Often it's asymptomatic in children or very mild. Sometime within the next 4 weeks, in predisposed children, they move on to phase 3. Some will have a pulmonary phage. They may have a cough or congestion. They may come in with some infiltrates or a mild pneumonia. It is somewhat related to sex hormones because that can express the ACE receptors, which is what COVID is targeted towards. This is why COVID is more severe in adults than it is in children, especially prepubertal children. This activates the macrophage system and stimulates the T helper cells, which then stimulate the B cells, but again, re-stimulates the macrophages and causes the activation of the next step of the hyperimmune response. And when I was talking about genetically predisposed, we have seen that it's more commonly in Hispanic and African descent groups versus less common in Asian and Caucasian ethnic groups. So how do we treat it? Well, first and foremost is supportive care. We always start with the ABCs, get your stabilize and support IV fluids. If you need to, start inotropes like epi, norepi, get your echo and your EKG. Steroids are still somewhat controversial, but they've been shown to be helpful in the studies that we've had so far. If they're having enough distress that they need to be intubated, do that ahead of time before you have to transfer, because you want a stable airway. And of course, if they're very unstable, significant cardiac decompensation, they may need to go on ECMO. We always want to cover for bacterial sepsis with broad spectrum antibiotics until we have determined that it really is MIS-C. So if you're thinking this could just be a septic shock kit, so definitely start them on the Rocephin and Vanco until you can further elucidate the next steps. Once you figure out it's MIS-C, stop the antibiotics, because at that point they're overkill. Once they're admitted to the peds for a PICU, remdesivir, if they are actually just beginning their illness, is still considered a helpful tool, but it's not helpful in MIS-C itself. It's only helpful for acute COVID infection. And as previously mentioned, MIS-C often shows up after the initial infection. If they haven't had an EKG or echo on the floor, they should get one. They should also be treated with IVIG and aspirin like you do for Kawasaki's, because this will still help prevent coronary artery dilation and aneurysms. Again, we also want to consider steroids. If they're still significantly ill after the first dose of IVIG, they can get a second dose of IVIG. And then we start looking into some of the monoclonal antibodies and antagonists. So I can't say the names of most of these medications, but they're what we call biologics. If they are in DIC or seem like they're developing thromboses, consider heparin for anticoagulation, especially if they're going to be immobile for quite a long time. This is another way of seeing how to stabilize and treat hospitalized patients. We do stabilization, immunomodulation. First, we start with IVIG, then we add steroids. Last but not least is the biologics down here. If they need antiplatelet therapy, aspirin, low-dose aspirin is an option. You can also do heparin or we don't do Coumadin that often in kids. We generally start with heparin when we are anticoagulating them. This is more information if you want specifics on how to dose the IVIG. It's 2 grams initially, and then the second treatment is 1 to 2 grams. Aspirin, you start with high dose, and then you go to low dose once they're afebrile, just like you do with Kawasaki's, which we'll review next. And steroids, there's different protocols depending on how sick the child is. If they're in active infection, you actually do not want to do steroids, though. That's an important thing to be aware of, because steroids can make an active infection worse. And then here's the doses for the biologics based on weight. The good news about Miss C is that mortality has been relatively low. Most of the kids do respond to IVIG, and those that don't do respond to the biologics. Almost all of them have full recovery, even resolution of their cardiac dysfunction. We are hoping that continued vaccination to prevent COVID will help limit or prevent some Miss C, but it's only as good as people getting the vaccine. Since it is an immune-mediated illness, there is a theory that some of the vaccines could predispose to Miss C, but we haven't seen this prove out yet. So it does need some more research in this, especially for those genetically susceptible. Now, one thing to keep in mind is that Miss C, like you said before, is diagnosis of exclusion. What can it also be? Kawasaki's, toxic shock, secondary macrophage lymphohistiocytosis or macrophage activation syndrome. So Kawasaki's is typical versus atypical. Now, in most kids, Kawasaki's is for younger kids, whereas Miss C is in older preteens and teenagers. There is a subset of Kawasaki's who can come in shock, which looks a lot like a shocky kid with Miss C. And bacterial sepsis. They will also have extra higher lab extremes and most likely will have dilation of the coronary arteries and or aneurysms. And they're more likely to have treatment failures. So these are the ones that get treated with a second dose of IVIG and or the biologics. With toxic shock syndrome, it's again a super antigen, but immune mediated, that causes non-selective T cell stimulation and cytokine release, very similar to how Miss C responds. But you're going to find some evidence of Staph aureus or strep pyogenes to cause these and exotoxins. These kids will be a little bit older, more likely to age group of Miss C, but you won't have quite as big of extremes, and they're less likely to involve the cardiac system. MAS and SHLH, primary HLH is a genetic predisposition that causes degranulation of natural killer cells and cytotoxic CD8 lymphocytes. This results in the ability to eliminate the antigenic stimuli that causes the cytokine storm. So basically, those people who are genetically predisposed, the minute they see the antigen, they just release everything. They go into a cytokine storm because they've released all their granules and it's overactivated the immune system. And that subsequently causes other cells like macrophages to, it kind of plugs into the system lower onto the, if you go back here, it's plugging in here instead of up here. So we're plugging in here and going back up there because of the genetic predisposition to HLH. Oh. And that ends up leading to organ damage and hemophagocytosis. You can see this on histology. It's secondary when it's triggered by an autoimmune or inflammatory condition, or which will be called macrophage activation syndrome. So medications, malignancy, infections, anything that causes autoimmune. So just about any autoimmune condition can lead into macrophage activation syndrome. And it looks a lot like MIS-C. This is kind of a table that I jury-rigged from this article about the comparisons of MIS-C, Kawasaki's and shock and toxic shock syndrome. Most kids with Kawasaki's are younger, MIS-C and toxic shock are older. Most of the people in shock will be in shock. They'll have low hypotension. MIS-C might have hypotension, depends on where they are in the process. Almost all of them will have mucous membranes involvement. Almost all of them will have a rash and peeling skin. Very rarely will Kawasaki's have altered mental status. So that's one way to tell that this isn't Kawasaki's. Almost all of kids with MIS-C will have vomiting and diarrhea, where it's rare in Kawasaki's. Respiratory distress is rare in Kawasaki's. So it's just an interesting way of differentiating between these different illnesses. Okay, case 2. I'm sorry, I don't have, let me see how much time. Okay, I gotta talk fast.
May I ask a couple
8-month-old
questions about MIS-C?
Yes, absolutely.
Okay. So I'm sorry if I missed it, but did you have the incidence of this?
We don't quite know the incidence. They're thinking it's about 12 to 14% of the kids who have been exposed to COVID can be at risk for it, but the actual incidence is much less than that. So I can't give you the exact numbers, sorry.
Okay. But I mean, do we have have they done, is this something they're keeping track of with case reports, like we've seen 1,000 cases
Yeah.
in California or something like that?
Yeah, there's case reports and they're doing studies on it right now. I think probably in California it was, hang on one sec. Let me see if I can find that data for you really quick.
It kind of seems like it's basically treat the symptoms and check if they have any of these other things. It doesn't sound like there's anything kind of specific that you have to do for this as opposed to other inflammatory cases. Is that right?
Not necessarily. It's just be
Okay.
aware of it is
Yeah.
mainly the point is that there is this thing that is associated with COVID. So it's another thing to keep in mind when you
Okay.
see a kid who's really sick.
Okay.
Um,
Thanks.
And that's the main reason for the cardiac concerns, right? Is that the MSC? I know for the teenagers and college students, getting an echo for a while was recommended. Is that because of the potential of MSC having a role?
right, right. And it's the because a lot of these kids will have asymptomatic initial COVID infection and not realize that they're still at risk. I don't know that it necessarily needs every echo, but I definitely think a thorough history and physical and if they're outside of the 4 weeks of presentation, they're more likely to not be affected by MIS-C. But if they're within 4 weeks of being exposed to COVID, it's definitely worth exploring, especially if they're still not feeling quite right. Sorry, I'm not able to find the incidents. If I find it, I will send it to Bridget and send it out to you guys so that you can have that information as soon as I can get it to you.
Thank you.
Are we ready to move on?
Yes, thanks.
Okay. So case 2 is an 8-month-old female with 5 days of fever. She's been fussy and difficult to console. She has red eyes without drainage, some swollen nodules on her neck, just on one side, bright red lips and tongue, diffuse maculopapular rash on trunk and extremities, including her palms and soles. And her vitals are as followed: slightly tachycardic, not super tachypnic, normal blood pressure for age, saturations are okay. Labs show elevated acute phase reactants and neutrophilia, and her echo shows coronary artery dilation. So this is Kawasaki's. Kawasaki disease is pretty common. We see probably a couple every year. So it's an important one to be aware of. Also known as mucocutaneous lymph node syndrome. I don't know anybody who actually calls it that. We always call it Kawasaki's or KD. It's the most common type of vasculitis in childhood, and it can be lifelong. The actual infection or inflammation itself is self-limited. It usually only lasts about 12 days. So if they don't get treated, the fever and stuff should not last more than 12 days. There are significant morbidity and mortality associated with coronary artery aneurysms, myocardial contractility, and heart failure, MIs, arrhythmias, and peripheral artery occlusion. These are the chronic issues, and they don't necessarily completely go away. Whereas in MIS-C, it does go away. This does not. Mostly inflammation of medium-sized muscular arteries. They'll be associated with bilateral non-exudative conjunctivitis, chapped lips and strawberry tongue, the rash, swollen red hands and feet. This is actual cervical lymphadenopathy is actually unilateral more commonly than not. They'll also start with URI symptoms or possibly GI symptoms, less likely. Mostly it's usually like a fever and malaise. Any baby who has any kid with a fever for 5 or more days, we always worry. And these features are not always present at the same time, and they don't always show up in any specific order. This is the most common time over presentation that we've seen. So your rash can kind of come and go. You definitely get desquamation after a little while. And sometimes you can get pitting and Bose lines in the nails. We'll review that in a little bit. The fever lasts usually even up into the daytime. I've seen fever as long as 10 days before. So you can have arthritis, you can have myocarditis. The aneurysms usually show up as you're getting better if you're not treated. Ideally, we want to treat here or here before they get to there. The lips and conjunctiva tend to get better faster. The cervical lymphadenopathy, a lot of times we don't even see it, but when we do, it goes away pretty fast. The thrombocytosis lasts for a while. So I'm going to be a little more thorough on the signs and symptoms on this illness. Starts with a fever. It's very minimally responsive to Tylenol and Motrin. Generally, it's over 38.5. It may go away if you give the Tylenol and Motrin somewhat, but it always comes back. And it's every day for 5 days. There's no break. Conjunctivitis is bilateral, non-exudative, usually bulbar injection with limbic sparing. Usually begins within the onset of the fever within days. So like day 2 or day 3. It's very red. They are often light shy. They don't want to be in bright lights. So if you have a fussy baby that seems to get better when you go into the shadows, that might be why, because their eyes are being annoyed. It's about 70% of babies can have a transient anterior uveitis, but you have to catch it. You have to catch it while it's still here. This does resolve kind of on its own. If you do end up are able to catch the uveitis while it's still there, it's more likely Kawasaki's versus one of the others. You're not going to see uveitis in Miss C. So if you notice, it's bulbar. It's not the lid down here. It's not the limbic area. It's actually the sclera and the bulbar sclera that's usually affected, and it's very brilliantly red. Mucositis. This is where you get the strawberry tongue. It cracked red lips. The strawberry tongue, reason why we call it that is because the papillae are actually sloughing off and it's causing inflamed glossal tissue. You can have the tongue without the chapped lips. You can have the chapped lips without the tongue. You can have neither. You can have both. You're unlikely to see ulcers or vesicles or exudate on the tonsils. So if you see these things, it's something else. It's not Kawasaki's. I love this picture because it looks very much like this picture, but that's actually a strawberry. And in this picture, you can really see the chapped lips really well. But see, she doesn't really have much chapping of, well, she won't, that's actually a picture, but you don't see as much chapped lips on this one. But. All right, the rash of Kawasaki's. It's polymorphous. It usually begins the first few days of illness and progresses, starts from a little bit of redness, and then eventually will develop peeling of the skin, usually of the hands and feet. It can be macular, morbilliform, or even purgatoid, trunks and extremities at the same time. You're not likely going to see vesicles or bullae because this is not that type of illness. It triggers the rash in a different part of the epidermis. It can cause a psoriaform eruption in those kids who are predisposed but have not actually been diagnosed with psoriasis. So you may see a first-time psoriasis in association with Kawasaki rash, which is not always something you would think about. And if you have a kid, especially from Mexico or a immigrant, if they have a BCG vaccination, you can see some crust formation around that area during this illness. This is a typical non-specific macular rash. This one's a little more erythrodermic, more macular. You can see the chapped lips. It's kind of all over. And extremity changes, this is usually the last part you'll see. It's swollen hands and feet. And these kids can be pretty, I mean, a lot of times these are chubby kids to begin with, but their hands and feet are more swollen than typical. They're going to have red palms and or soles. And when they start feeling better, the desquamation starts, and it usually starts around the nails. Sometimes you can see nail changes, Bowes lines, which are just these white creases that go along the edge of inside the nail. In very young infants, you can see pale or cyanotic hands and feet because the perfusion is just reduced. Even though they're febrile, they just clamp down their central, the peripheral vasculature. Gangrene is very, very, very rare. It's theoretically possible, but I've never seen it in 25 years. So if you can see here, this is really red here. That's the erythroderma. And these kids are actually starting to have the desquamation. It starts around the nails and it goes down. And this page will show a little more on the desquamation. This sheet light is less common. It's more common to be something kind of like this, but it can sometimes get pretty significant. Lymphadenopathy. Cervical lymphadenopathy is the least common feature. It can be absent as often as 3/4 of the time. It generally is anterior cervical lymph nodes, usually the one over the sternocleidomastoid muscle. It's usually one single nodule. about 1.5 centimeters. Ultrasound of the neck can show multiple small nodes that look like a bunch of grapes on the ultrasound. If you see diffuse lymphadenopathy on both sides of the neck, or you see splenomegaly, there's something else going on. It's probably not Kawasaki's. That lymphadenopathy here is unilateral lymphadenopathy. The one thing to keep in mind is that you want to rule out retropharyngeal process or abscess, because those kids can have fever and swollen neck as well. So now arthritis is not included in diagnostic criteria, but it is found in about 25% of patients. They can come up with large joint or oligoarticular arthritis. Sometimes even some polyarticular, usually if they're involving their hands. Again, it's self-limited. It does not cause chronic deformity. So this is just an arthritis inflammation of the joint at time of illness. It goes along with all the acute phase reactant elevations. But systemic onset, just juvenile idiopathic arthritis can present very similar to incomplete or atypical Kawasaki's. But your echo is going to be normal. IVIG will not hurt kids with arthritis. It actually might help them feel better, but it won't. There's no arterial involvement, so it's not going to protect against aneurysm. But if you have a kid and you're not sure if it's arthritis, systemic onset arthritis versus Kawasaki's, give the IVIG. You're not going to hurt anybody that way, and you can protect them from coronary artery aneurysms. So here, this is kind of subtle because their hands are still pretty, see how puffy their hands are, but there is arthritis here in some of these joints. And so this one, it's kind of in these joints here, a little bit swollen, but the whole hand itself is swollen too. So definitely another thing to keep in mind. Other non-specific findings in the first 10 days, diarrhea, vomiting, abdominal pain, again, like Miss C, irritability, cough, decreased oral intake. This is common for anybody with a fever. Myalgias, as well as arthralgias, as well as arthritis. Now, when you're looking at the labs on Kawasaki's, there's no particular lab that's diagnostic. It's kind of the whole picture paints the story. The CRP will resolve prior to the ESR, so the ESR may be elevated for weeks. And it can be increased by giving the IVIG. So draw your ESR before you give your IVIG. Usually after about the 7th day of illness, you can have platelets up to 1 million. This can be a correlation to how severe the coronary artery changes can be. So if you have a kid with who's been febrile for 7 days and they have a high platelet count, you definitely want to get an echo sooner rather than later. Sometimes they can develop thrombocytopenia, and these are the kids who can go into DIC, and that's also pretty rare. But it's an unstable patient. If you have a kid who you think has Kawasaki's, but they have thrombocytopenia, you definitely want to do platelets and their coag panels. They will start with leukocytosis, but then it improves over time. You can often see a left shift. Your ferritin can be over 5 times normal. Sometimes if you develop macrophage activation syndrome, because you can get this with Kawasaki's as well as Miss C, your ferritin can be as high as 5,000. So this is kind of a atypical or incomplete Kawasaki evaluation. We have a kid with fever 5 days and 2 or 3 of the clinical criteria, or an infant less than 6 months, a fever of 7 days without any other explanation. First thing you want to do is get your labs. Do they have a CRP and ESR that are low? If yes, then you just continue to follow and consider doing an echo if you see desquamation or other signs or symptoms develop. If you have an elevated ESR CRP, then you want to look at other things, your CBC, your platelets, your albumin, your liver function, and at this point, you also want to do a UA because they can have an asymptomatic pyuria that is not a bacterial infection. So you'll just see high white count in the urine. That's another supporting feature of Kawasaki's, especially incomplete Kawasaki's. And if you have a positive echo, that's not diagnostic, but it is highly suspicious. So if you have an echo with a coronary artery dilation, you want to treat them. It's should be, I think, diagnostic, but it's not. Everybody says the echo is not diagnostic, so you still consider it as a possibility. High triglycerides, low sodium, elevated liver function tests, as well as macrophages or monocytes in the CSF can be signs of macrophage activation syndrome. So you definitely want to keep an eye out for those kind of things. Normocytic, normochromic anemia can be noted in over 50% of patients with Kawasaki's. You can, as I said before, your urine can show pyuria, which might be urethral in origin if it's done by catheter or tap. So this is the one of the few times where a bag specimen is actually helpful. So clean catch or bagged urine is a good for micro, but we're not thinking infection here. We're thinking pyuria. We're thinking inflammation. Abnormal liver functions like ALT, AST can be abnormal in up to 45% of patients with Kawasaki's. Sometimes they can develop an obstructive jaundice from high drops. We're not sure why. CSF can show pleocytosis without low glucose or elevated protein. If you do have a kid with arthritis and you do an arthrocentesis, you'll see a pleocytosis with 125 to 300,000 white cells per micrometer squared. Usually it's neutrophils, but they can also be monocytes. Abnormal lipid profiles, including elevated triglycerides and LDL and decreased HDL, are found when they're actively ill, but can return to normal after treatment with IVIG. Or if they're not treated, if you see a kid who has never been treated but had a fever for 12 days, then and they have abnormal lipids, you may consider, that they may have Kawasaki's. It'd be worth getting an echo on them. Hyponatremia, another thing that you can see associated with increased risk of coronary artery changes. So to diagnose, you need to have a fever for greater than 5 days. And this is for typical Kawasaki's, at least 4 of the following: conjunctivitis, mucous membrane changes, extremity changes, rash, and cervical lymphadenopathy. For atypical, you need fever or 1 of 2 or 3 of the following. It's also, clinical judgment and supportive lab findings. So when in doubt, treat, because you're better off treating than not treating. Or you can always call a cardiologist and ask their perspective, but they'll probably say treat. Atypical, less than 6 months of age. Any baby less than 6 months of age with a fever for more than 7 days is Kawasaki's until proven otherwise. If you're any age with a fever greater than 5 days with only 2 or 3 criteria, you're incomplete or atypical Kawasaki's. So this is an atypical algorithm. So you have fever 5 days and 2 or 3 criteria instead of the 4. You want to look at the characteristics and then you say, is it consistent or is it not consistent? Well, let's look at our labs. Our labs show, well, it's low ESR sed rate. So we're just going to follow daily. If the fever continues for 2 more days, go back and recheck because this is still concerning. If the fever resolves, no peeling, no follow-up. If they peel, like when I showed you before, the desquamation happens later on in the illness. If you see peeling, that usually means something happened and they probably have Kawasaki's. If they have elevated CRP-ESR, but you have 3 other laboratory criteria, you want to treat. it should be echo and treat, not treat and echo. If they have less than three other criteria, like say they have pyuria but nothing else, you still get the echo. The echo is going to be kind of your gold standard at this point. If the echo is negative and your fever persists, you want to go back up here and do it again, or consult an expert, usually a cardiologist. If your fever resolves and you have a negative echo, you're probably safe it wasn't Kawasaki's. So a CRP greater than 3, ESR greater than 40, WBC greater than 15, normal cytic, normal chromic anemia, platelets over 450, steropyuria, elevated AST, hypoalbuminemia, and an echo with abnormalities. So aneurysms usually don't show up until after 10 days of illness, but you can have coronary arteritis or decreased contractility. You can also have dilation without aneurysm, and you can have pericardial effusions as well as mitral valve prolapse. And this again reiterates the atypical stuff. If you have an abnormal echo in any of these situations, treat. When in doubt, treat. Your differential for Kawasaki's, I didn't put on here, but I should. This is kind of an old slide. Add Miss C on here because that's one of the big differentials. Measles, echovirus, adenovirus, EBV, you're not going to see as much systemic inflammation and you're not going to have swollen hands and feet. Group A strep or toxic shock, you're not likely to have eye involvement or arthritis. Toxic shock might have conjunctivitis and or generalized edema. Scarlet fever may have desquamation, but you have that sandpaper rash. Rocky Mountain spotted fever has headache and GI symptoms. They may be meningitic. Drug reactions, Stevens-Johnson serum sicknesses, you're probably not going to have as much eye involvement. And if you do, it's more exudative eye involvement and limbic versus bulbar. And you can only have mild or normal CRP-ESR. And then for JIA, they probably won't have the eye findings, but you have generalized lymphadenopathy with splenomegaly. Treatments, how do we treat Kawasaki's? It's 2 grams IVIG over 8 to 10 hours. I usually pre-medicate with Benadryl and Tylenol, not just Benadryl. You do have to treat this like a blood product because it is a blood product. You have to do like the Paul Gans and all that, and be aware of possible hemolysis. You can also transmit infections sometimes, and or transfusion reaction. You also want to treat with high-dose aspirin, 30 to 50 milligrams per kilogram per day, until fever-free for 48 hours. And then you go to low-dose aspirin, 3 to 5 milligrams per kilo per day. And then you echo every 2 weeks, 6 to 8 weeks, and 2 months, and then frequently thereafter. And there's another graphic I'll show that explains some of these risk factors. Your cardiac complications include aneurysms, decreased contractility, heart failure. You can get an MI. So if you have a kid with an MI, they may have probably had Kawasaki's when they were younger. Arrhythmias and peripheral artery occlusion. Non-cardiac, often uncommon, shock, multi-organ dysfunction, macrophage activation syndrome. This is more common than some of these other things. Altered renal function, acute abdominal catastrophes where they lose perfusion to their abdominal organs, and or hearing loss. So cardiovascular changes, these changes are not part of the diagnostic criteria, so they don't count, even though they do. They don't, but they do. It's just used to support the diagnosis. So during the first 7 to 10 days, you can have tachycardia that's out of proportion to the fever. So you have a kid who has a temp of 102, but they're tachycardic in the 150s. That doesn't make sense. So you probably want to think something else is going on. If you hear a gallop sound, something is going on. And my general rule is if I hear a gallop, I'm getting an echo. I don't care what's going on. I'm getting an echo. If you hear muffled heart sounds, this can be a sign of effusion, either cardiac or pleural effusion, but muffled heart sounds is concerning. And 30% of kids with Kawasaki's have dilation at diagnosis. That's dilation, not aneurysm. Just be aware of that. After 10 days of illness, you're going to see the frank aneurysms. Fusiform aneurysms of the brachial arteries can also be visible and or palpable in the axilla. So this is a couple graphics. These are echoes that can show some of the dilation. So you can see some dilation here. This is a remodeling, and this is a cath that shows. And here, this is a computer workup imaging showing some of these aneurysms and these arteries. The left coronary artery is one of the most important ones that develops aneurysms, but you can also see it on the right side as well. So prognosis, mortality is rare, 0.1 to 0.3%. And usually this is from severe cardiac abnormalities or aneurysmal rupture, MI, or fatal arrhythmias. In Japan, and I think this is we haven't been able to reproduce this in the US. It's just in Japan. They noticed more increased mortality in the first 2 months, then afterwards it stabilized. There is definitely more morbidity, depending on the severity of coronary artery involvement and how quickly you catch it and treat it. If you treat it, you can often avoid a lot of this. If they're detected in the acute and subacute phase up to 8 weeks after disease, they can be asymptomatic 10 to 21 years later. So treatment makes a difference. If your dilation is less than 8 millimeters, this will often regress over time, and aneurysms less than 6 millimeters will often fully resolve. Those kids who have coronary artery dilation will be followed indefinitely. Giant aneurysms over 8 millimeters are the highest risks of MIs and need to be followed pretty regularly, causing coronary artery occlusion. So some kids can have this again. It's not common, but 2% of kids who've had Kawasaki's have had it again. 6.9 per 1,000 person years. Often it's in a kid who's less than 3 years of age who did have cardiac sequelae during the first episode. They usually reoccur within the first 12 months. Poor prognosis is a kid who's less than 1 year of age, if they're atypical Kawasaki's, and if there's acute phases acute changes during the acute phase. All right, so the difference between Miss C and Kawasaki's. Miss C's older, Kawasaki's younger. Most of these kids are less than 5. These kids are usually 8 to 11. I think when I talked to Sutter, they had a lot of kids 12 and 13, and they actually tended to be a little bit more on the heavier side. Males, a little bit more than female, but not much. This one, you see a little bit more males to females on that side. Oops, sorry. Black and Hispanic ethnicities are more prone to Miss C. Asians are more prone to Kawasaki. GI symptoms are very common in Miss C, less common in Kawasaki's. Myocardial dysfunction is more common in Miss C, less common in Kawasaki's. They can both get, like 48% will get inotropes, whereas 5% get inotropes here. And this is more the Kawasaki's with shock syndrome. Multi-organ dysfunction is required almost for Miss C. Multi-organ dysfunction is not required for Kawasaki's. You're going to see elevated markers for both. Your treatment is very similar. And you have a little bit higher fatality rate of Miss C, but I think that's because we're still learning about this illness and not able to prevent it as much. This is a kind of a graphic of the difference between the two. I think, no, that's my. So any questions about Kawasaki's? So it's 1:15. I think that's pretty much my time. I actually got through what I expected to get through. Like I said, I have a bunch more cases and more rashes to review. If you guys are interested, you can always get my PowerPoint.